we have QRS complex. In the QRS complex, as you know, the amplitude of a normal QRS complex is 5 to 30 millimeter, and the duration is 0.06 to 0.12 second. QRS complex, when assessing the QRS complex, you need to pay attention to the following characteristics, which are width, height, and morphology. Okay, about the width, so as you know, that can be described as a narrow. It means that less than 0.12 second, or broad, more than 0.12 second. It occurs in bundle, branch, block, also narrow, occurring in SVT, for example. Okay, this is about the width. About the height of the QRS complex can be described as a tall or small. Tall implies ventricular hypertrophy, while small is less than 5 millimeter in limb leads and less than 10 millimeter in chest leads. Okay, and about the morphology, to assess morphology, you need to assess individual waves of QRS complex. So here we have Q wave. Q wave, isolated Q wave, can be normal. A pathological Q wave is more than 25% the size of the R wave that follows it, or more than 2 millimeter in height and more than 40 milliseconds in width. This is called Q wave pathology. So a single Q wave isn't a cause for concern, so we have to look for another, for example anterior, inferior, for evidence of previous MI. So if you have a Q wave like that, for example, this is the normal P and QRS. This is Q wave. Well, in pathological Q wave, we have a deeper Q wave. For example, this is pathological Q wave. Okay, and then we have RS waves. RS assesses the R wave progression across the chest lead from small in V1. If you look here, we have a small R wave, okay, in V1 to large in V6. This is R wave, which is large, while here in V1 is small. Okay, then transition from S, which are larger than the R wave, to R wave larger than S wave should occur in V3 and V4. From the S, which is larger than the R, to R wave larger than the S wave. Okay, for progression, it means that S wave is more than or larger than R wave through to leads of V5 and V6. If it is, S wave is larger than the R wave. Okay, can be a sign of previous MI, but can also occur in very large people due to poor lead position. So here we have ST segment. In the ST segment, the duration of ST segment is usually around 0.08 second. Is the part of ECG between the end of S wave and the start of the T wave. For example, this is the P wave, QR. This is, for example, QR, and this is P wave, and this is T wave. So the end of the S wave is here, and the start of the T wave is here, so it's called ST segment. Okay, in a healthy individual it should be an isoelectric line. Okay, it means at the same line, okay, not elevated and not depressed. So here we have ST elevation and ST depression also. In the ST elevation, this is ST elevation. If you look at, this is the P wave, this is Q, this is R, and ST. If you look at, this is the isoelectric line, but here this is elevation of the ST. This is ST. So this is called ST elevation. Is significant when it greater than 1 millimeter. Greater than 1 millimeter, or what we call 1 small square. In 2 or more contagious limb leads, or more than 2 millimeter in 2 or more chest leads. It's important, you have to know. Okay, so when we say ST elevation, it means that greater than 1 millimeter or greater than 1 small square. It means that there is a 2 or more contagious limb leads, or more than 2 millimeter in 2 or more chest leads. It's important, you have to know. It's most commonly caused by acute full thickness MI. Okay, acute full thickness MI. It means that transmural. On the other hand, we have ST depression. For example, here we have ST. This is ST depression. This is isoelectric line. It means that more than 0.5 millimeter in more than 2 contagious leads indicate myocardial ischemia. Okay, this is important and about the ST elevation and depression.